Today on Primary Care, we talk with the former Secretary of Health and Human Services, Dr. Louis Sullivan, to get his perspective on how health disparities affect the nation. Later, we'll talk with Wright Lassiter, the president of the Henry Ford Healthcare System, about the role that hospitals play in reducing disparities. Stay with us. Primary Care starts right now. Hello and welcome to Primary Care. I'm Dr. Lonnie Joe. Dr. Louis Sullivan is a well-known champion of public health. He served as Secretary of the United States Department of Health and Human Services under President George Herbert Bush. Dr. Sullivan has spent his career addressing health disparities and inequities. I had the honor of sitting down with him to discuss how we can go about eliminating health disparities in this country. Dr. Sullivan, seeing that disparities in this country, especially as it relates to African Americans, still exist, how would you characterize the progress that we've made the last several years?
Well, it's an interesting story. The health of all Americans has improved over the past several decades and indeed this century. But in spite of that, the difference in health status between whites on the one hand and African Americans on the other hand still is quite different. In 1900, there was something like a 15-year difference in life expectancy between whites and blacks. Now it's around 7 to 8 years, so it's narrowed, but it's still there. We also have higher death rates from cancer, diabetes, obesity, heart disease, and a number of factors. So while we've made progress, we really still need to make more progress to close the gap.
So basically, we need to make sure that the general public understands what healthcare disparity really is and what those numbers really mean.
Oh yes, very definitely, because we know we can eliminate them. It really has to do with lifestyle, has to do with access to health care, the kinds of foods we eat, do we exercise regularly, and other things. So indeed, we have a lot to do, but we know we can get there.
How does the cost of health care factor into this whole discussion of disparities?
Cost of health care is a very important factor because everyone is concerned about the high cost of care, and certainly when people have marginal incomes or no income, it becomes even more so. And because African Americans on average have lower incomes than whites, getting health care tends to be more of a challenge. In addition, many African Americans remember bias in the system and therefore have less trust in the system. Less trust in hospitals, in doctors. Are they going to get the right treatment? Are they going to be treated fairly, appropriately, or will they be the subject of an experiment? All those factors tend to influence whether or not they use a system. That's something that we have to work on also.
So, the World Health Organization ranks the United States as number 37 in the list of countries that are providing health care to its citizens. But we spend more money than anybody on health care. Where are we missing the boat in terms of shifting those numbers around?
Well, there are a lot of things that go into that expenditure that we have. First of all, the United States is the most innovative nation in the world in terms of new therapies, new medical devices, more biomedical research, new pharmaceuticals, et cetera. So we invest a lot more in the system, and we get a good return on that investment. When I went to Washington as Secretary of Health and Human Services in 1989, we had the AIDS epidemic right in front of us. October of '89, I approved the first drug for federal reimbursement for treatment of AIDS, AZT. At that time, if you had a diagnosis of HIV infection, you could count your life expectancy in months or 2 or 3 years. Today, because of the investments we've made in addressing this research and new therapies that have been developed, we have more than 30 drugs now, and people are living years rather than months, 10, 15, 18 years with this condition suppressed, and they're working. They're raising their families, their children. So we've made tremendous progress, but that's because we invested dollars, starting with $4.2 billion in President Bush's first budget that we recommended to him for this. So that is one of the factors. But other factors are we don't use our health system efficiently. Too many of us use our emergency rooms as our primary care facility. That's absolutely the wrong place. The most expensive facility, and the care that you get really suffers because it's discontinuous. No follow-up, no continuity. So we have to really work to see that our citizens use the system in a smarter way, a more efficient way, and a less costly way.
So research, part of that number, invaluable in terms of what we do in providing health to this country. Speak a little bit about the socioeconomic factors that surround the health care of the African American in this country.
Yes, we know from a number of studies that health is related to level of income, whether or not you use the system effectively. It's measured by, also or influenced by your level of education. People who are college graduates do better than those who are high school graduates or high school dropouts. So those factors, level of education, level of income, trust in the system, whether or not you have a primary care physician who sees you, knows you and your family, and really can recommend what your things that should be done during that year or that month, et cetera. All of those are important. Too many people don't have a regular physician. And as I said previously, use the system inefficiently. We need to have people coming in for regular checkups, also getting preventive services, vaccinations, also being careful of what their diets are, having diets that don't have excessive calories or fat. So all of those things influence health.
So unemployment, inadequate housing, food deserts in urban areas, all of those are factors in terms of how people make choices, and it affects health. The Affordable Care Act, historic landmark legislation, probably going to supersede Medicare as affecting the laws that mostly affect people in this country. Medicare did that in '63. As a matter of fact, you know, the National Medical Association was the only medical organization who supported it. And now, right now, we're celebrating here at our convention the 50th year anniversary of Medicare. But now we have the Affordable Care Act, which is going to affect more people and hopefully produce better outcomes. How do you see that historic legislation beginning to make the tide shift?
Oh, yes. The Affordable Care Act is a very important piece of legislation. I think perhaps the most significant legislation we've seen in the last several decades coming out of Washington. What the Affordable Care Act does is close in those gaps that were left from Medicare and Medicaid. Medicare, of course, was for people over 65 or with disabilities. Medicaid was for poor people, but not every poor person was eligible for Medicaid. So the Affordable Care Act really expands eligibility, provides greater care, sets up insurance exchanges so that people who have income can really get premiums that are more affordable and competitive. So the Affordable Care Act indeed already has brought some 15 or 16 million more people into the health system, but it still needs to do more because we had 47 million people uninsured in the year 2010 when the Affordable Care Act was implemented. So the Affordable Care Act is a great bit of legislation. It'll take time for it to be completely implemented, have its major impact, but I'm very pleased that it has been achieved, and I think that we'll see the results, and we're already seeing the results in our population.
Yeah, a good start in the right direction.
Absolutely.
Good. Yeah. Let's shift gears here for a second. Let's talk about this wonderful document that you produced, Breaking Ground, your most recent book. It's excellent publication. Tell me, how did you decide to write this book?
Well, I really was fortunate. As a child, first of all, both of my parents were very supportive of me and my older brother. I was born in Atlanta, but by the time I was age 2, we had moved to rural Georgia, where my father established a funeral home. But the schools in rural Georgia in those years of segregation were not good at all. My parents were so committed to my brother and me getting an education, they sent us back first to Savannah for a year, but then to Atlanta after that to attend school. So I finished high school in Atlanta. And while in Blakely, there was one black doctor in southwest Georgia, 41 miles south of Blakely in Bainbridge. At age 5, because of Dr. Griffin and what he represented to me, I said, I want to be a doctor. I want to be like Dr. Griffin. Dr. Griffin cured people. He helped them. He had great influence and respect in the community. He was very successful, highly regarded. He had a brick house. He had built a 25-bed brick clinic. So he was really someone who was very important. He had powers that other people didn't have, and he really was doing a lot of good in the community. I had other role models. When I went to Morehouse College, every student at Morehouse College emulated Dr. Mays, our president. Dr. Mays was eloquent. He was really articulate, very moving in his talks. He dressed well. He traveled. He was really going all over the country, speaking out against segregation and for equal rights, etc. So I wanted to be like Dr. Mays. And what Dr. Mays told me and the other students there, you can be exactly what you want to be, but whatever you choose to do, you should commit yourself to doing it so well that no man living, no man dead, or no man yet to be could do it better. He said, if you commit yourself to that, when they're looking for someone in your field, they will have to consider you. You may not get the job, but it should not be because you're not prepared. So those are the factors that influenced me, and I had a very good career. I really went to Boston University to medical school in 1954, the year of Brown versus Board of Education. I couldn't go to medical school in Georgia because of the laws of segregation. I was the one black student in my class. First time living in a non-segregated environment. And I wondered, how is this going to work out? Am I going to be accepted by my classmates? Am I going to do well academically with these guys and gals who went to Princeton and Amherst and Harvard and Columbia, etc.? Well, we had our first exam about 3 weeks later in gross anatomy, and I got an A. So I relaxed. The rest of my years in medical school really were great. I was class president for 2 years, and I really then ended up with postgraduate training in hematology and went on the faculty at Harvard and then Boston University. And when Morehouse College decided in 1973 they wanted to start a medical school, I was recruited back to Atlanta to develop the medical school. So that was an opportunity that came along. So there were all of these things, and of course later became Secretary of Health and Human Services under President George H.W. Bush. So a lot of my friends said, you should really write about this. I first wrote a history of the Morehouse School of Medicine because I thought it was important to document how this institution developed, which, by the way, was greatly facilitated by the interest and support of the Georgia State Medical Association, which is the state chapter of the National Medical Association. The doctors in Atlanta and the rest of Georgia, black physicians, really pushed very hard for this medical school. So they really played a very important role in the development of the Morehouse School of Medicine. So when I finished that, my friends still said, you need to do your autobiography. So I did it, and it's done very well. It received the Image Award for autobiography and was a finalist for the Phyllis Wheatley Award, and just recently was deemed by the Georgia Center for the Book to be one of 10 books that all Georgians should read. So I'm very pleased with the recognition it's gotten.
It's important to capture that history and important for us to know it. Very good. Andrew Young wrote the foreword to this book, okay? Obviously you impressed him well enough to do that. Do you still feel the same way now or that you did then when you were actually putting this together? Has anything really changed that would make you say, I think we need to make a shift here? Or is it full steam ahead on all of these issues that you just ported out with the historical perspective?
Full steam ahead, because while we have made significant progress on the one hand in improving the health of all Americans and certainly African Americans, we still lag, as you mentioned, behind where we should be, ranking 37 among nations of the world in our health status. That's not good. We're spending more than any other nation. We have the most innovative scientific enterprise with research, new pharmaceuticals, new medical devices. We have strong educational institutions. So the question is, why are we 37th? And I say it's because we have a distribution problem. What I mean by that is that not everyone in America benefits from all these strengths that we have in our system. We don't have enough diversity, ethnic and racial diversity, among our nation's doctors, nurses, dentists, and administrators and policymakers. We don't have people in rural areas or in urban areas. And I say we need to have more diversity. We also need to really expand those kinds of health professionals who work with physicians. A small town may not be able to support a full-time physician, but we could have physician's assistants, nurse practitioners working with physicians to expand them. Same in dentistry. So there are a lot of things that we need to do, including having our citizens use the system more effectively. 25% of what we spend in healthcare is either wasted because of duplication or ineffective therapy, or there's also some fraud in the system that we need to work to get rid of also. If we could capture that 25%, we could expand care without raising costs at all. But that's difficult to do.
Or a small percentage of it as a start under the Affordable Care Act.
Oh, yes.
Excellent. Very good. The Honorable Dr. Louis Sullivan joining us here on Primary Care at the National Medical Association Convention in Detroit. Thank you, Dr. Sullivan.
Thank you. My pleasure.
I'm Bea Smith, and I suffer from Alzheimer's disease. Brain disease affects millions. Unfortunately, minorities are underrepresented in research, so we may not be getting the best possible care. The Brain Health Registry collects vital information online for free. So please tell your story. I'm telling mine. Help find cures faster by visiting brainhealthregistry.org.
There is a growing realization among healthcare providers that a focus on healthcare disparities is central to improving patient outcomes. Here to talk about how hospitals can reduce patient risk and improve patient care by eliminating disparities is Mr. Wright Lassiter. Mr. Lassiter is president of the Henry Ford Health System, where he oversees all hospital and service operations for the $5 billion organization. Wright, thank you for joining us.
Thank you very much.
Last year here in Detroit, the National Medical Association had its annual scientific assembly and convention. And at that time, you guys made an announcement of a collaboration between the research arm of the NMA, the Cobb Institute, and Henry Ford Health System in an effort to eliminate disparities. Would you comment on that? Tell us about that relationship.
Sure. You know, for us, it was a great privilege to announce the partnership because we are very, very committed to eliminating disparities in healthcare. And so for us, one of our concerns is how do we ensure that persons of color, underrepresented minorities are fully represented in research studies that can produce benefits in the clinical environment. And so we believe that the partnership between Henry Ford Health System and the Cobb Institute would help us do just that, and it would spur the investments we've made with our Health Disparities Research Collaborative to increase both the number of individuals participating in research studies, the kind of data that's coming out of those research studies, and the ability for Henry Ford Health System physicians and physicians around the country to apply those findings to improving care.
You know, this is an all hands on deck kind of approach to this situation called disparities in healthcare. You know, personally, my mantra has always been, until there is parity, we will always have the disparity. So that brings in state, local governments, the national, federal government in all types of ways. What is the relationship between the Henry Ford healthcare system with those entities, the local health department, the state of Michigan, Department of Community Health? What kind of relationship is this there in an effort to begin to eliminate these disparities?
Well, you know, I would go back to the phrase that you've heard for many years, that it takes a village. And so certainly a healthcare system, a hospital, a group of physicians are not able in and of themselves to make the kind of impact that we'd like to make. And so clearly you have to involve all parties to assist. What local municipalities can do certainly is around their public health departments and assisting around public health data, public health research. Clearly there are things that when you think about improving health, healthcare is a relatively small percentage of that. And so healthcare systems have to partner with organizations that can assist us with really identifying the social determinants of health and then dealing with how do we address those along with addressing the more direct healthcare and health system issues.
We're in an era of the Affordable Care Act, probably the the number one piece of legislation ever introduced in this country outside of Medicare that affect the lives of the average everyday American. How has this affected the ability of the Henry Ford healthcare system to do what it does?
So it is very difficult to ever deal with disparities when you don't have basic access to healthcare and healthcare services. And so I'm a great supporter of the concept, the philosophy, the investment that this country has made in bringing us into closer to universal health care, to everyone having access. So for Henry Ford Health System specifically, the way that we have benefited, first and foremost, is that many Michiganders are now insured and have access to health care. That gives them more impetus, more comfort with accessing the healthcare system. You know, unfortunately, we are oftentimes about intervention, and it's hard to intervene when you don't have the party there that needs intervention. And so when people are more comfortable with being able to access the healthcare system because they have less financial barriers, that is a benefit. About 500,000 people in the state received new access to care. We enrolled about 25,000 individuals into our Medicaid health plan during 2014 and 2015. And so that certainly gave us access to more individuals who were able to participate more fully into our healthcare system.
We're going to take a short break. Stay with us. We'll be right back. Right, we have a lot of new things to deal with, new kids on the block, a lot of alphabet soup. ACO is part of the Affordable Care Act, accountable care organizations. Do you see this approach going forward, having the history of the Henry Ford healthcare system, which probably mirrors what an ACO looks like? Do you see going forward that the ACO is going to actually be able to help us impact this disparity issue that we have in the delivery of healthcare?
So I do, Lonnie. I think accountable care organizations are really about shifting the focus to value and outcomes as opposed to doing more things to patients. For Henry Ford Health System, because we serve communities with large numbers of underrepresented minorities, anything that supports our ability to not be in what I would call the traditional rat race of fee-for-service medicine, but to be able to potentially deliver services that focus on prevention, wellness, outcomes, will be of value. And so we have not historically participated in accountable care organizations because we also own a very large insurance company, and we really believe that our Medicare Advantage products and Medicaid managed care products were sufficient to allow us those incentives. We are one of 21 organizations in the country that have been approved for what's called the Next Generation Accountable Care Organization, which we launched in January of this year. And we do very much believe that it allows us the ability to treat communities of color in a way that will deliver better outcomes than we could do through the traditional fee-for-service medicine program.
Back to the physician side. Physicians are under a tremendous amount of pressure now. It used to take 6 months to get a real change in this business. Now it might be 6 weeks, and everybody's shifting, adjusting, jockeying for position to make sure that outcomes can be achieved. We're functioning under outcomes-based medicine directive, which is bleeding over to outcomes-based administration, outcomes-based accounting. How is Ford helping its physician population deal with this?
So I think one of the best ways to describe this is to talk about data, technology. We have made some significant investments in technology around electronic medical records, in our research institute investments. And one of the best ways to provide physicians with tools around outcomes is to make data available. When you have all of your patients in an electronic medical record system with longitudinal data, it gives physicians the ability to understand trends on the interventions that they are putting in place and how those things then attribute to the care of the patient and the outcomes of the patient. With our various research initiatives, that also allows our physicians to have real-time data that helps them assess the best care available. And then technology now brings in, with the World Wide Web and the internet, a host of outcomes-based databases that are at a physician's fingertips to be able to ensure that what they're doing, what they're prescribing, what they're suggesting is the best based upon current research.
So we can look forward to not seeing these gaps exist, whether they are inner city, rural, suburban, doesn't matter. We're heading toward laser focusing on outcomes in this industry.
I would say yes, and then I'd add one more thing. Now that the human genome has been explored, the whole field of precision medicine is going to change the practice of medicine radically. I've been to a few sessions where people are talking about, the traditional chemotherapy regimen works great, presuming you have a standard set of genetics that would suggest that your body will react as predicted to this chemotherapy regimen. Well, if you have a slight genetic aberration, drug X doesn't affect you, Lonnie Joe, potentially the way it might affect me, Wright Lassiter. And those are the kinds of breakthroughs that are happening in medicine now. And this is not theoretical. This is not only in some high-end research lab. These are things that can be brought right to the bedside and right to the practicing physician to be able to make changes in their practice.
It's actually happening in clinics today. It's fascinating science and gives us a lot to look forward to. If nothing else, stimulates your juices in terms of practicing medicine.
Absolutely.
We've been talking with Mr. Wright Lassiter, the president of the Henry Ford Healthcare System, one of the country's leading healthcare administrators. Wright, thank you for joining us. It's certainly a pleasure. We'll do it again.
Thank you very much.
Thank you. For Primary Care, I'm Dr. Lonnie Joe, and we'll see you next time.